Hello, and welcome to the Medicine Matters Rheumatology podcast. I'm Claire Barnard. In this series of podcasts, we are exploring the repurposing of rheumatology drugs for COVID-19. For this episode, focusing on JAK inhibitors, we are talking to Dr. Marwan Bukhari. Marwan is a consultant rheumatologist at the University Hospitals of Morecambe Bay NHS Trust in the UK. First of all, Marwan, could you outline what the rationale is for using JAK inhibitors for the treatment of COVID-19?
Right. So the rationale really came from the fact that we began to understand the pathology of COVID-19. And the pathology really is about a big cytokine storm that happens within that stage of the disease, where we have an increase in interleukin-6, amongst other things, and other cytokines that are very familiar to the rheumatologists. And we've been very aware that some other drugs that have been coming along have been licensed, have been shown to work. And so we've had anecdotal and case report, and now even we've got established treatments with IL-6 inhibitors that have been shown to reduce your length of stay and reduce your morbidity from COVID. So we're very much aware that there is a place for modulating your cytokines in patients who have fallen ill and are starting to get the autoimmune issue with the autoimmune inflammation that happens with COVID. And so JAK inhibitors became much more prominent in our thinking, because if you actually take a look at the disease itself, it isn't just inflammation, but there's also a thrombotic component to your disease. So when you look at the lungs in patients with COVID, you don't not only have got inflammation, you get clotting and thrombosis. And the JAK inhibitors actually do have an influence both on the cytokines with the big IL-6 approach, which we've shown in rheumatoid arthritis, and they also have got an element of interfering with the thrombotic process. So they work inside the cell, and because they're tablets, they're they're easier, have a shorter half-life, and we're very familiar with them. And we've got three licensed JAK inhibitors, with the fourth one which is imminent. And so we're very familiar with how we can modulate disease activity in patients.
So what do the data so far tell us about the efficacy of JAK inhibitors in COVID-19?
The data so far on the efficacy of JAK inhibitors for patients with COVID has been mostly case report based. And there is an ongoing trial called the TACTIC trial that involves the giving baricitinib, as well as giving ravulizumab or standard care, which is ongoing, which is due to report at some point. We've had one positive trial, again with baricitinib, where they've actually shown that there is some efficacy there, and we're still to see the detail of the trial. But from what we have seen in advanced publication, that there is an efficacy that has been seen there. The other JAK inhibitors, again, you will see quite a few case reports and advanced notices out there coming through. But I'm very happy that what will happen is that we will get the papers in due course, and they will actually confirm that actually cytokine modulation in this way will work. So if the IL-6 inhibitors will have worked, I think the JAK inhibitors will just follow suit, and we're going to get these coming through fairly quickly.
So you're one of the principal investigators on the TACTIC-R trial, which is investigating baricitinib. Could you tell me a bit more about the aims of the trial and what the treatment groups are and what it hopes to find out?
So within the TACTIC-R trial, which is a trial of patients who've been admitted with COVID who still they don't need intensive care as yet. What we have been doing is getting patients who've got active disease and randomizing them in one of three groups. So usual care, which is standard of care, which includes dexamethasone and might possibly include other drugs as well, or we randomize them to ravulizumab, which is a complement inhibitor, which is used in paroxysmal nocturnal hemoglobinuria, or give them a baricitinib in the dose of 4 milligrams. And these patients, they get the baricitinib for 5 days, and then we look at things. The trial still is in its stages and is recruiting ongoing, and we'll probably have an interim analysis at some point. The rationale being really is that if you inhibit complement and you stop the inflammation within the cell, you can actually get some good response with your patients. And we're hoping that we'll have this as standard of care. We wish that we didn't have as many patients coming through the system to to undertake the trial, but as we've got a lot of COVID currently in the hospitals, we're going to try and answer the question as quickly as possible.
So we've talked so far about JAK inhibitors for patients with COVID-19 who don't have rheumatic diseases. Are there any data available, observational studies of rheumatology patients who take JAK inhibitors on a regular basis for their rheumatic diseases and how this might impact COVID-19?
There has been quite a bit of data. So the Lancet Rheumatology did publish quite a few papers looking at this and looking at the patients who with rheumatic disease who've been on a JAK inhibitor. And there's not been a signal as yet, but we're not sure whether this is observational data. Of course, will have some amount of confounding. And for example, in rheumatoid arthritis, by and large, every single cohort we've looked at hasn't shown that they're any worse with COVID. However, if you take other rare diseases like polymyalgia rheumatica, etc., we've just shown very nicely in a population sample that you had an increased mortality in patients with rare rheumatic diseases. And so, if you take a big enough cohort sample, you can find this. So this was a study looking at looking at the big linkage of the general practice research database and lumping together all of the rare rheumatic diseases. And then they found that compared to May 2020 compared to May 2019, there was an increase in mortality, which they attributed to COVID, although it could have been just for the fact that we neglected the care of those patients in that period of time. So we don't know the answer, but there might be further evidence for it. But patients with rheumatoid arthritis treated with JAK inhibitors, which is the only reason we would give JAK inhibitors currently, the signal is that you won't necessarily have any higher amount of COVID, and possibly you might have a better outcome if you do get COVID, although we don't have that data definitely.
In our episode on hydroxychloroquine, we talked a lot about the impact of investigating it for COVID-19 on rheumatic disease patients, so drug shortages and those kind of problems. Thinking about the JAK inhibitors, are there any concerns about that kind of thing regarding JAK inhibitor shortages or any other concerns?
The concerns really about using JAK inhibitors isn't that there'll be a shortage, mainly because most of the trials aren't using the JAK inhibitors for a long period of time. These drugs have got fairly short half-life, and the trials are just looking at very short, sharp periods of time for patients who are seriously ill with COVID. So we don't envisage it. The vast majority of people have still not really started using the more recently licensed JAK inhibitors. So there'll probably be quite a large amount of baricitinib, for example, which is the newest one just licensed, or filgotinib. So I don't see it as being a supply issue, and patients who are already on it, of which there's not as many nationally as there are on the other drugs. Of hydroxychloroquine, there's thousands and thousands of patients. Well, I'll give you a good example. In our cohort here, a population of 350,000, we've got 130 patients on JAK inhibitors. So not as many patients are on it, while we've got hundreds more who would have been on the other drugs. So if the other drugs are being given, then we would worry. So hydroxychloroquine, just to give you the same example, for our population of 350,000, we had more than 1,100 patients on hydroxychloroquine, while we've only got 135 on a JAK inhibitor. So it's a scale that's slightly different. The only other thing that it would stop doing is that the JAK inhibitors are due to be licensed for use in other diseases like psoriatic arthritis and inflammatory bowel disease. And this is the only thing that we would worry about, in that this will delay the licensing of the JAK inhibitors for other indications. And I think other indications is possibly do need to have more agents to deal with them, but maybe that will happen just after we deal with COVID.
So in your view, what are the most important directions for future research on JAK inhibitors and COVID-19?
I think the most important future look at JAK inhibitors and COVID-19 is to determine exactly at which point to give the COVID. And not reading between lines, but seeing the patients that we've been recruiting into the trials, you should really be the patients who are showing what would be the beginnings of a cytokine response. So no evidence of infection and a raised CRP should basically be what would alert you to the fact that these patients might benefit from having their cytokines modulated. And those are the patients you'd want to give a JAK inhibitor to. And the good news is that the JAK inhibitors will be less costly for a 5-day period of time than actually giving an intravenous IL-6 inhibitor, which is much more expensive.
Thank you very much to Marwan, and thank you for listening. This podcast was produced by Medwire News for Medicine Matters Rheumatology. Please subscribe for more podcasts on repurposing rheumatology drugs for COVID-19. Medicine Matters Rheumatology will also be covering the latest research and guidance on managing COVID-19 in patients with rheumatic diseases. You can visit rheumatology.medicinematters.com for updates.